So we have a few minutes left, and thank the faculty. Everybody stayed on time. Great. Any questions or comments from the audience before we sort of address the panel? I see a lot of experienced operators out there. You guys, I'm sure, have some comments. Good.
Yes, please. Yes,
yep.
one.
For Dr. Beckman, is there any advantage to subsequent patency in supervised exercise prior to intervention?
You could have just leaned over. The evidence for that is really limited. I would guess that there is, and there's been a big move more in surgery for prehabilitation. And I would bet because of the improvement in the metabolic function of the vessels, and the decrease in inflammation and oxidative stress, that there would be some improvement in patency, but it hasn't been established in any kind of reliable way.
So probably one question in addition to this. It's obvious that the combination of exercise therapy, lifestyle modification, and revascularization makes the biggest benefit. How do you approach your patients in trying to convince them that not the simple short interventional procedure is the end of their responsibility for themselves, in order to motivate them for an exercise program? So this is in line with the first question. Do you start exercise training before indicating the intervention in general, or is this a case-based decision?
I would actually, so I'm in the middle of where you just described. So what I would say is the first thing I discuss every single time is exercise now that it's paid for. And you have a conversation about it and what it means. And I have patients who come to me from really small towns in Tennessee that are not close to any rehabilitation facility, and it took their brother-in-law to be able to drive them in that day. And for that patient who said there's absolutely, not loud enough, really? Okay. For that, okay. So for that patient who will have no access to rehab, I'll offer them an intervention because it's a one and done, and we'll see how they do. For most patients, I'd much rather they start with exercise. The lifestyle changes that we all talk about, there's only two, in my opinion, that make any difference for the legs at all. Number one is cigarette cessation. I think that's really clear. Cigarette cessation reduces amputation by all of the terrible studies that we've seen before, going back 25 years, but there will be no randomized study in this area. But for me, that's number one. So I usually tell the patients that no matter, I will do everything for you, and everything I do will be the equivalent of you stopping smoking. So you have one job, I have 12 jobs. This doesn't always convince people to stop smoking, but they get the point. The second one is actually putting them on statins. Whether you believe it or not, I think statins affect the metabolic function of muscles, and that's why in the 3 or 4 trials that were done, 2 with Simva, 1 with Atorva, there was an increase in walking distance before pain, but not total claudication distance. So I think those 2 things make a big difference. For me, though, people don't get to be 120 pack year smoking patients without developing a certain set of habits. And so I find it's impossible to change every bad habit at once, and I try not to do that. So I want to make a couple of big breakthroughs, show them they can feel better, and then build on it. So I'll usually start with, how can we get you to stop smoking, and either exercise right up front or revascularization for the people that won't have good access to exercise.
Yes.
Patients we suspect have aortoiliac disease, but make sure we get a CTA prior to an aspirin.
So the question was, in patients with aortoiliac disease, when do you get a cross-sectional imaging, CTA, MRA ahead of time? Let me send that to Dr. Soukas.
Well, I think it depends on a number of factors, of course. From a practical standpoint, one of the most basic is what's their underlying renal function. And so if a patient has significantly impaired renal function, then I'm going to think very carefully about getting a CTA. Duplex ultrasound, if the patient's not significantly obese, you can get some pretty good look at the aorta. Again, if they're not obese, you can get if you have an excellent ultrasound tech, you can usually get some good imaging of the iliac vessels as well. And secondly, a lot of it depends on their clinical presentation. I mean, if someone has resting ABIs that are very, very low, then and they're incredibly symptomatic, then they're much more likely to have an underlying CTO. But as was illustrated by the case that I showed earlier, I mean, the patient that I had actually didn't even have a drop in her ABI with exercise, yet she had a 6 centimeter occlusion of her common iliac artery. So if they're young and and if they're just presenting with claudication, I don't think that by and large you need to get a CTA, but if you suspect that a patient has an underlying occlusion, in those patients I certainly think it can be very helpful in terms of planning your strategy. Are you going to go retrograde, antegrade, or are you going to have 3 access sites, both groins, and a brachial artery or radial artery? So if they're very symptomatic, if the suspicion is high that they're going to have a CTO, then I think getting an MRA or a CTA, as long as their renal function allows it, is a very nice way to plan your strategy. And then also, of course, I was cringing. We've all been there when Sahil showed his case of the iliac perforation, and having a CT ahead of time, so that way you can sort of marshal the troops. So make sure that you've got an OR in standby. Make sure you've got one of your surgical colleagues who's around and available. Get that blood bank type and screen ready to go. So in those situations, I think if you have the luxury of being able to do a CTA, I think it'd be very helpful.
I'll just add one quick thing to that. I think additionally, a CTA is very helpful for a patient who has an extensive history and it's not with you. Because it gives you, again, kind of a roadmap, so when you get to the operating room or you get to the cath lab, you go into it with a little bit more of a structured plan as to option A, B, and C. So for me, it's a little bit of, in the operating room, we call it an archaeologic dig when we don't know someone and it's like the 3rd or 4th time we've been in that groin. Well, a CTA gives you a 3-dimensional view of a patient like that, so that, you don't need to have the left arm, the left arm, the groin, everything kind of ready to go. You can just decide, okay, here's what my problem is, this is what I'm going to do, and you can be a little more focused.
So with that, we close the session. It's 10 o'clock. The faculty are here if anybody has anything that you want to discuss. Thank you very much for attending.